When we identify a mobile tooth in an adult patient, how quickly do we associate it with loss of alveolar bone support and periodontitis? Almost immediately. But is that assumption always correct? A section of the book Dental Emergencies, edited by Mark Greenwood and Ian Corbett, made me reconsider this seemingly straightforward clinical presentation. In the chapter Restorative Dental Emergencies, authored by J. M. Al-Salihi and P. F. Ashley, tooth mobility is presented as a clinical sign that may reflect considerably more than periodontal disease. The most thought-provoking message is simple: a mobile tooth can occasionally be a manifestation of underlying osseous pathology, including neoplasia. In other words, what initially appears to be a routine periodontal case may require an entirely different diagnostic approach. The authors consider tooth mobility within a broad differential diagnosis. The cause may be relatively straightforward, such as a loose or fractured restoration, dental caries, trauma, or a problem involving a crown. However, the underlying pathology may also be subgingival and include a vertical or horizontal root fracture, occlusal or impact trauma, internal root resorption, or complications associated with tooth preparation and post-placement. Tooth mobility may also occur following luxation injuries or as a consequence of loss of supporting alveolar bone. It is within this latter category that an important diagnostic consideration emerges. Loss of supporting bone should not automatically be regarded as synonymous with advanced periodontitis. The differential diagnosis proposed by the authors also includes pathological processes involving the jawbone, such as cystic lesions and neoplasms. At this point, an everyday dental finding assumes an entirely different clinical significance. If we decide in advance that we already know the cause of the mobility, there is a risk that every subsequent finding will simply be interpreted as confirmation of our initial assumption. The patient presents with a mobile tooth, there may be changes affecting the supporting periodontal tissues, and a diagnosis of periodontitis therefore appears logical. Yet a plausible diagnosis is not necessarily the correct diagnosis. For this reason, the authors emphasize the importance of a comprehensive history, careful clinical examination, digital assessment of tooth mobility, percussion testing, and radiographic examination using images obtained at different angulations. Particularly important is their observation that a mobile tooth, although it may not initially be perceived as a dental emergency, requires thorough investigation and timely management. The reason is significant. The consequences of diagnostic error may be serious and, in certain circumstances, potentially life-threatening if an underlying osseous neoplasm is misdiagnosed. This does not mean that every mobile tooth should be regarded as a potential malignancy. The real clinical challenge is determining how to distinguish periodontitis from a cystic lesion or neoplastic process. Both an excessively alarmist approach and an overly rigid diagnostic approach would be inappropriate. The key message is that mobility is not a diagnosis, it is a clinical sign. Our responsibility is not simply to identify the most common explanation and end the diagnostic process there, but to determine whether the entire clinical picture is genuinely consistent with that explanation. If the degree of mobility, radiographic appearance of the bone, distribution of osseous changes, or other clinical findings are inconsistent with the expected presentation of periodontal disease, the differential diagnosis must be broadened. It is also noteworthy that the authors emphasize assessment of the occlusion, both in maximum intercuspation and during mandibular excursions, because occlusal overload may also contribute to tooth mobility and associated symptoms. Thus, the same clinical sign may result from fundamentally different pathological mechanisms, from a defective restoration, root fracture, or traumatic injury to periodontal loss of attachment and bone support, or underlying osseous pathology. For me, this is the most important lesson from this chapter. Experience allows us to become faster diagnosticians, but speed becomes dangerous when it turns into diagnostic automatism. The more frequently we encounter a particular clinical finding, the greater the risk that we will classify the next apparently similar case as the same condition before we have actually established the diagnosis. Therefore, The next time we encounter a mobile tooth, perhaps our first question should not be, "How advanced is the periodontitis?" A better question may be, "Why is this tooth actually mobile?" Because sometimes a mobile tooth is more than simply a tooth that moves, and behind an apparently routine clinical finding may lie a disease that we cannot afford to miss.